My friend Vince recently had two posts on Facebook that resonated with me, and I wanted to put some thoughts down on what they meant. Now, what I'm going to describe will probably generate more questions than answers, but I think this is a good place to start the discussion. So here's the two posts. The best at clinical reasoning typically leads to less profit in the insurance model, and because we can't measure being good at our profession, everyone can say they are good. So in order to compare ourselves to our peers, it's not just enough to look at the scores of our outcomes, but it is also important to understand the test that is being scored. One of the suggestions was to use a tool called PHOTO, which helps clinicians track their outcomes and even includes some risk adjustment parameters and allows you to compare outcomes across different patient populations. The problem with this is that we're assuming that the different patient populations as well as the different diagnoses are homogeneous. If we say that student A got an 88% on their math test and student B got a 92% on their math test, which student is smarter? What if student A is taking a test on calculating flux densities through a sphere and student B is taking a pre-calculus class and they're taking a test on a unit circle? Student B is testing on the foundations of a topic while student A is testing on a more complex application of the topic. Referring to a math score is similar to referring to a specific outcome score. We might be referring to the same subject such as math, English, or physics, just like we refer to an Oswestry, NDI, DASH, or foot and ankle disability index. This is info we need to accurately score clinicians. Let's take an example of Achilles tendonitis, which you've seen 100 times in your clinic. We have three different clinicians, but all three came up with the same diagnosis of Achilles tendonitis. Clinician A is going to recommend an MRI and a heel lift. Clinician B also found some foot pronation, and so they're going to recommend some arch supports, and they're going to offload the tendon until the inflammation goes down and then begin a strengthening program. Clinician C also found a little bit of tension in the Achilles tendon, and so they're going to recommend some A-stim, and they're going to also recommend home stretching, and they're going to start right away with a strengthening program. So all three clinicians have the same diagnosis, and they all have the same initial outcome scores. The question is, based on these different interventions, will there be different outcome scores at 4 weeks and 12 weeks? What about a patient who has a more pronounced dorsiflexion deficit? If we treat all of them the same, then will there be different outcomes? So the exam findings help us to classify what we want to do, and we may choose different interventions based on that classification. It's not enough to just look at the diagnosis as a determinant of what we do with a patient, but we need to understand the different components that make up our approach. Have we looked at the different regions of the body and taken into account regional interdependence? Are we looking at the Achilles in isolation, or are we looking at how the foot might be influencing the Achilles tendon? How are we classifying the patient and the condition? Do we have multiple classifications, or do we have a single classification, or do we have a couple classifications with one that is much more pronounced? How well are we able to classify the patient? Because when we classify the patient, we can then presumably pick an intervention or a treatment that best addresses the dysfunction in that classification. So if we have a classification that is predominantly a joint-related issue, we're going to choose a treatment that addresses the joints. But what if we choose an intervention that addresses the joints and the muscles and the nervous system? It may be more specific for some things, but it may be less specific for others. So ideally, picking the appropriate classification allows us to pick the appropriate treatment and presumably have better outcomes. So part of measuring how good we are as clinicians means understanding what the questions are on the test. And presumably, if we're better clinicians, we can better recognize the most important clinical elements, and we can address those directly. If we address them directly and quickly and efficiently, then we may need to see the patient less. And in a fee-for-service model, seeing the patient less means less revenue. So we're going to make less money. So Understanding how all these different parts work together and how we score them is an important question, but I think being able to score our ability to classify is what can help us identify who the best clinicians are, and then hopefully use that as a model for reimbursement, and then that way the quality of the clinician will be rewarded for doing a better job even though we're seeing the patient less. So I look forward to your comments and questions and continuing the discussion. Thank you.